So thank you all for tuning in and for having me here as part of your lunch hour. I'm Brian LaMoreaux. We're going to talk about balancing arthritis pain management. That's me in the photo. That's me here live. My hair is, like so many of us, a good deal longer. But after growing a beard for a few months, I did, revert to clean shaven again. So again, thanks for joining, and we're going to jump right into this. What we're going to talk about today is living with OA or osteoarthritis, or RA, rheumatoid arthritis, two of the main forms of arthritis, what our goals for treatment might be, understanding some of the treatment options and risks and benefits that come along with those, and then how to find out what's best for you. As a disclaimer, this is a general talk. I'm not providing individual medical advice here. We're just talking about topics and options, and I'm speaking on behalf of Horizon Therapeutics. So we can jump into this with our first topic, living with osteoarthritis or rheumatoid arthritis. And these are the two most common forms of arthritis out there, with apologies to gout, which is also quite common. And so osteoarthritis is the one that we might call the wear and tear arthritis, or the old age arthritis. Now, that's not entirely accurate. It can easily occur in folks in their 30s and 40s. And if people live to their 70s, 80s, 90s, they will almost universally have some form of arthritis. As we get so much better at treating heart disease and cancer, we have made improvements in arthritis, but we've not found cures here. And so it can start in any joint, get worse over time. And as this happens, joint pain and stiffness, all of that can limit what you can do. And that leads to some other undesirable health outcomes. If you can't move around as much as you'd like to, it's possible you might gain weight, even get diabetes, or be at risk for heart disease. And if you're not moving, you might get weaker. You might have some muscle loss, and that could result in falls, potentially fractures. And so all these bad things that come along with osteoarthritis, we're looking to avoid as much as possible. Now, in contrast, rheumatoid arthritis is a systemic inflammatory disease, whereas osteoarthritis is more of a local inflammation right in the joints is where you see it. But with rheumatoid, it's really all through the body. And this is one of those diseases where the body actually attacks itself. You get these chemicals in the body that are supposed to help us fight infections, and they wind up actually attacking the joints and also other parts of the body. The eyes, the mouth, lungs, heart, and skin. You get all these other problems with rheumatoid arthritis. And just like with osteoarthritis, if you have this bad joint pain consistently, it can be tough to exercise. You can gain weight. And because rheumatoid arthritis can actually attack the lungs and the heart, even if you have this disease, you're at higher risk for heart disease. And of course, then not being able to move around contributes as well. So, both are pretty serious forms of arthritis. Rheumatoid, again, is systemic or body-wide inflammation. And osteoarthritis is going to be more local, right at the joint, but there is inflammation there as well. So what are our treatment goals for these? Well, again, I mentioned there's no cure for osteoarthritis, but we do have a few ways to kind of address it. There's kind of non-drug methods, which we'll talk about in a second. There are medications that help. There are devices, braces and things that can help. And ultimately, there's surgery if those things don't work. With rheumatoid arthritis, really, we tend to start aggressive and hit hard. You want to control that inflammation as much as possible. And this doesn't work for all patients. All the medicines don't. So you can use any number of options out there to help control the rheumatoid arthritis inflammation. And we call this treat to target. You've got to calm the inflammation in the joints and the body so that the patients don't have it and that they can do better, reducing long-term complications and problems, and of course improving their functionality and their overall well-being. So what do these therapies and options look like? So the lifestyle adjustments, we talked about this briefly. In general, kind of eating a healthy diet, maybe a low inflammation, minimal carbs, minimal sugar if you can. So that means we're higher in protein and probably animal fats, and fruits are fine, all of that stuff. Maintaining a healthy body weight. We have a scale up there. That's really quite an important part of this. For every pound you can lose off your midsection, it's actually 4 pounds off of your knees. And so you really get a very strong effect of weight gain, but it's also very challenging, especially when you can't move around as much as you'd like. And then we have a dumbbell there, but it doesn't have to be that type of exercise. It really can just be walking around or getting in a pool and walking or swimming. There are lots and lots of ways to exercise. And again, everything in that box to me is something we should probably all be doing. There's almost not a patient where you say, you know what, eat whatever you want and don't bother moving around. That is simply not something that doctors in the medical community say, regardless of disease. So this is good stuff, but it often isn't enough. Then we come to the next box, medications. And we've got topicals, we've got pills, we've got some injections. These are really good. We're going to go into more detail there in just a second, but I want to address the other boxes first here. DMARD stands for disease-modifying anti-rheumatic drug. These are the ones that we give in rheumatoid arthritis patients to control that inflammation. Biologics are similar, they're just a little bit more potent, and they squash that inflammation even more. And so these only work for rheumatoid arthritis and other similar autoimmune or inflammatory diseases, but they do work very well for most patients. They don't get them all the way there, but they work. And then finally, over there, surgery. And this is certainly a last resort. We don't like to do these joint replacements. In fact, we rarely do them in rheumatoid arthritis, but they are still done plenty in osteoarthritis. But they're considered kind of the last option here, and you don't want to have that, especially if you're younger. You want to put that off as much as possible. So, the box that we really have control over, where we can help most of our patients, is going to be this medication one. And so I'd like to go into more detail on some of the medication options for rheumatoid and osteoarthritis and talk about, what these look like and maybe who they're right for. So that's this section, understanding treatment options and risks. So we've got a nice little table here of the different types of therapies that we can use. And first we have pure analgesics, which means they're going to help pain, but they're not going to do anything for inflammation. And so one option here is Tylenol. And Tylenol is called acetaminophen. It's very safe. It's not all that effective. For patients that really, truly have long-term chronic pain, from my experience, they're going to tell you pretty quickly, Tylenol is not going to be the answer for me. I'm going to need something a little more than that. Now, the other medication class in the analgesics that only addresses pain are opioids. And opioids have been all over the news. 10, 20 years ago, we really were giving a lot of opioids because they really help pain, but they have some problems. They're addictive. They can depress your drive to breathe. They interact with other medications, and they interact with alcohol and marijuana. And so, people had a lot of problems with opioids. I practiced medicine in Ohio for a number of years, and we saw a lot of this, and it's really everywhere in the country. So doctors, and especially arthritis doctors, are becoming very hesitant to do this. And opioids have become a very kind of touchy subject. And I'm sure you've experienced this with your doctors as well. So that takes us to NSAIDs. And NSAIDs address pain very well, but they also address inflammation, which is nice. These can come in oral or topical forms. The topical is where you just kind of rub it on the joint that hurts, and you minimize your body-wide exposure that way. Whereas if you have multiple joints that hurt, or you're a rheumatoid patient, it's fine to take these by mouth. And we'll talk about some of the other risks with NSAIDs, but the important thing here is they address both the pain and inflammation, making them a nice choice for these arthritis, pain sources. Now we have corticosteroids, which are prednisone or other types of corticosteroids, and essentially these can come by oral or injection or even right into the joint options, and they're going to address both the pain and inflammation. Steroids are very potent at suppressing inflammation, and we'll go into that in a little more detail pretty soon as well. Now, hyaluronic acid, labeled here as a joint lubricant, this is for osteoarthritis in general. And part of the problem with osteoarthritis is patients lose the cartilage in between their bones, and the cartilage is the cushioning. So hyaluronic acid kind of gives some of that cushioning back in an ideal setting. Now, it works best, hyaluronic acid injections, it works best in kind of early middle arthritis, but most patients don't get it until they have later stage arthritis, where it's a little bit less effective. And again, it's only going to be for pain, not going to address the inflammation. And we just have a little box here. Opioids really aren't recommended as first line or routine therapy in any of these arthritises for the reasons that I talked about. You have to be a little cautious with those. So NSAIDs and corticosteroids, like to go into a little more detail on these because they both address the pain and the inflammation. And so let's start with steroids here. These are a very, very fast way to control inflammation. In rheumatoid patients, when they're first diagnosed, they often have a lot of pain, and that's because of all the inflammation. So the doctor, commonly a rheumatologist like me, will start one of those anti-inflammatory medicines to help this rheumatoid patient who's just been diagnosed. In addition to one of those longer-acting ones, we'll often give them a little bit of steroids early on, because the steroids are what make you feel better tomorrow. They'll work right away because they suppress inflammation so quickly. But we don't like to use steroids, at least not in kind of high, medium doses long term, because there's side effects. And we've listed a few of these here. It'll help you retain fluid, raise your blood pressure, raise your blood sugar. So your doctor really will always try to give you the lowest effective dose to both balance your pain and inflammation, and also to minimize your risk factors, including infections here. So some important considerations with corticosteroids, but they are a very important option in our rheumatoid patients, especially. Now, thinking about NSAIDs here, again, this stands for non-steroidal anti-inflammatory drug. These are, an indispensable part of addressing OA and RA pain. And doctors will choose these because they address both, right? You're not just going to get that pain or analgesic effect. It'll also help the inflammation, mostly locally with osteoarthritis. And an important point here is that unlike opioids, NSAIDs are not addictive. So you're not going to get those problems, which is important. Now, I'd like to point out a few of the side effects of NSAIDs, and there's a few of these that we can't do anything about. Cardiovascular problems. NSAIDs can raise blood pressure and maybe increase patients' risk for heart attacks and strokes, which we don't like. NSAIDs can certainly affect the kidneys, and patients with chronic kidney disease or kidney issues have to be very cautious using these NSAIDs. One other important one here is stomach problems or gastrointestinal issues. And what I'm referring to here are stomach ulcers. That's one of the third major categories of side effects with NSAIDs. And, unlike the cardiovascular and the kidney side effects, we can actually help or minimize the risk of these stomach side effects. We do that with a medication you might know as a proton pump inhibitor, or even one called an H2 blocker. And these kind of coat or protect the stomach so that you have a lower risk for these ulcers. And the important thing is we can identify which patients are at risk for these stomach ulcers. And we have the risk factors here. If you're taking a high dose of NSAIDs, if you ever had a stomach ulcer in the past, if you're above age 65, or if you're taking your NSAID with something like low-dose aspirin or steroids or anticoagulants. And so, any of those risk factors, even just one of them, puts you at a higher risk category for these stomach ulcers. So really, most patients that go on an NSAID need to be considered for this gastroprotective process so we can kind of help their stomach to tolerate the medicine. So how can we find what's best for you? Well, as we kind of talked about, a lot of these NSAIDs are over the counter, and some are by prescription. The higher doses are usually prescription. Those will be the true arthritis pain doses. And so to minimize your risk of these stomach ulcers, again, we can't prevent the heart or the kidney problems with NSAIDs. We have to pick our patients carefully, but we can give you focused medicines that will protect your stomach while you get that arthritis pain relief from your NSAID. And of course, in patients that might have heart or kidney problems, we can try to use topical NSAIDs, which are very effective, but are best if you have really between 1 to 3 joints that bother you. Once you have a lot of joints and it hurts everywhere, well, the topicals, if you have to put them all over your body, you might as well just take an oral medicine. It'll probably save you some time also. So it's important to talk to your doctor and consider medical conditions you might have. If you have or don't have heart disease and kidney disease, if you're going to be at risk for one of these stomach ulcers, then using a stomach protective agent with your NSAID or a topical NSAID, these are going to be really nice ways to go to help you do the best while you get your joint pain relief. Okay, so that was our talk. Thanks for sticking with. A few questions have come in here, so I want to just address these before we part. Someone again actually asked about the risk factors for stomach ulcer, and they ask, how many risk factors do you need before you kind of are considered medium to high risk? And so again, these risk factors are using a high dose NSAID, having ever had an ulcer in the past, being above age 65, or using a medicine like aspirin or blood thinners that might put you at higher risk. And really, if you have any one of these risk factors, you're considered high enough risk where we should give you an additional medicine to protect your stomach. All it takes is one. Okay, and another question coming in. Why choose a topical NSAID over an oral NSAID? And so this is a nice question. We kind of touched on this, but to me, use a topical NSAID if someone just has one or two joints that bother them. And also, if they have other medical conditions that are going to make using an oral NSAID a little too risky, someone with really bad heart disease or advanced kidney disease, or if they're, above age 70, 75, that's when I tend to favor a topical NSAID just to help those one or two joints. And the next question is related to that one. Do topicals work well for osteoarthritis and knee pain? And the answer is absolutely yes. These topicals are quite clever. They have the NSAID component, the anti-inflammatory component. They have it connected to something that actually helps it go through the skin. And so those two together, the NSAID that relieves the inflammation and pain with a different part that helps it get through the skin to the joint, that's how these topicals are so effective. And so yes, they absolutely can work. Someone else asks, is ibuprofen bad for my liver? It's a nice question. We talked about some of the side effects of NSAIDs, and I kind of focused on the kidney and the heart, but actually the liver can be affected. In patients that are taking NSAIDs, your doctor every 6 months or so will bring you in for a panel of blood tests, and they'll check your urine, your kidney, your blood counts, and your liver. So the short answer is yes, ibuprofen can affect your liver, and you should tell your doctor if you have any liver problems or use alcohol. But in general, the liver effects are a little bit less than the kidney or heart effects, and they can be monitored, so we can kind of keep track of those. Someone writes in, they take Tylenol regularly and Celebrex, and also some over-the-counters or supplements, things like turmeric and others. So Tylenol and Celebrex can be taken together as long as your doctor is kind of supervising that a little bit. With the herbal medicines, these are quite popular, and some of them actually do have some anti-inflammatory properties, referring to things like capsaicin and paraffin wax and Bengay cream, and there are others as well. These can be effective, and so there's nothing wrong with those as long as you check with your doctor to make sure none of those have interactions with your other medical conditions or therapies that you're on. And so someone writes in that they have rheumatoid arthritis and they are on a biologic therapy, but they still have some swelling. So what are their options? So this is a great question, and I think it's actually probably best posed to this person's individual rheumatologist. But in broad strokes, the biologic medicines, as we talked about, are very, very powerful. They are potent, and they will help reduce inflammation, but they might not get patients all the way there. And biologics can be used with other anti-inflammatories. They can be used with NSAIDs. They can be used with steroids. And so if your doctor has you on a biologic and you're close, I would say just add a little bit of something else, whether it's a low-dose steroid, another anti-inflammatory, or an NSAID as you need it. If that gets you all the way there, then you're great. You can stick with your biologic. Now, if the biologic has helped, but you still have a lot of inflamed swollen joints, then maybe it's time to think about a different biologic to kind of anchor or base your rheumatoid arthritis therapy on. This is all stuff that your rheumatologist can certainly address with you, and that would work. Someone else asks, what about medications like duloxetine for chronic pain? And so this is a really nice question, and there is growing data. So duloxetine is what we call a serotonin norepinephrine reuptake inhibitor, or SNRI. These can be used for things like depression and anxiety and things like that, but it turns out they also help some of the parts of the brain that process pain. So these medicines, they don't work for everyone, but they can be very effective and a nice kind of safe adjunct therapy that can help arthritis pain. So another nice question. This kind of speaks to the expanding options we have for addressing arthritis pain out there right now. So that may have been our last question. Again, I'm going to thank all of you for, we got one other question potentially. Someone says, nothing but meloxicam seems to help. Sure, so meloxicam is another non-steroidal anti-inflammatory therapy. It's kind of nice because you just take it once a day. What this means to me is that different people respond to different types of NSAIDs. And so, you might be on one for a while and you find it just kind of stops working. And it's important to tell your doctor that because there are lots of NSAIDs out there and your doctor can easily change you to a different one. I have some patients that go on one for 6 months, then we just change it to another one. And they have a little bit of a rotation schedule. Even though NSAIDs are not addictive, you don't really get habituation effects to them. people just find they're not as effective as they were over time. And so it's okay. If it works for you, I would stick on it. And if it doesn't, then I would switch to another one, and that's perfectly okay. So someone else asks about taking rheumatoid arthritis biologic medications in the age or era of COVID-19. And of course, COVID-19 is this virus that's taken over the world just about. And so this is an important question, and really I would just say talk to your doctor about it. In general, rheumatologists are doing is, unless someone has a very close exposure to COVID or they're known to have COVID, you just keep them on the rheumatoid arthritis medicines right now, because if you take them off, that inflammation is going to rise up and cause problems, and you're going to have guaranteed problems. And so a lot of us are just sheltering in place. We haven't had a lot of exposures. Unless you're going out to eat and going to bars, hopefully your exposure is low for this virus. But again, talk to your doctor. Most patients are staying on their therapies unless they have a known close exposure or they have this virus. Okay, so again, thank you for the questions. Thank you for listening. If you have more questions, you can please send them in. We will try to address them at some future time. But I'm Brian LaMoreaux. I'm a rheumatologist, medical director with Horizon Therapeutics. Thanks for having me, and I hope you enjoyed the session here.